Good afternoon. It's really great pleasure to be with you all today here. I would like to thank the organization committee and basically Dr. Wiam for the beautiful conference. As usual, for the 8th year now, it's really one of the best conferences that is run in our country, Bahrain. And it's a great pleasure to be with you all here. Uh, the topic is quite interesting because finally, as a nephrologist, we have some medication to talk about. We've been waiting for this for many years now, and finally something is happening. So we all know that chronic kidney disease is chronic. I mean, having a EGFR less than 60 with evidence of a kidney damage of a proteinuria, which is more than 3 months. It is progressive, irreversible disease, and it is silent with advanced stages. Now, the problem here is finally this progressive, irreversible. Hopefully, could do something about it. Many people, they don't know that CKD is more common than diabetes. We are almost like 1 billion now. And it is going to increase, and the death because of chronic disease is predicted to be increasing. Our region, unfortunately, it's in the hot area here. You can see it, like we have a very high prevalence of chronic kidney disease. Sometimes very nice to hear that we are having an opening of a new units for dialysis. But unfortunately, and this is very fortunate for our patient because we have great care, but this is very scary because the numbers are really increasing. And it's not only the chronic kidney disease, it's basically the diabetes and the heart failure, very high prevalence, and discontinuity of the CKM basically, the kidney disease, the diabetes, and the heart failure. It has great economic burden for any healthcare system. People with end-stage renal disease consume around 5 to 7% of the budget of any hospitals or medical organization. And one of the bad things here is basically that we have to focus on is proteinuria. And as we all know that if the proteinuria increase, then the cardiovascular mortality will increase. And if the GFR is basically reducing, then again, the cardiovascular mortality is increasing. I'll give you an example, very scary example here. If we have somebody who's 25 years old and he had end-stage renal disease, basically, started on dialysis, his risk for cardiovascular mortality will increase between 500 to 1,000 times. That means the heart of this person will be like the heart of somebody who is 85 years. So we have a really problem and we have to do something about it. So I'll give you an example. This is a typical patient that someone will, you will know many of us here, many of our diabetologists here. Mr. Ali, he's 58 years old, diabetic, type 2, for the last 2 years, blood pressure 137, just a borderline, EGFR 112, HbA1c 6.9, he's in metformin. He might be sending you his results on WhatsApp, or maybe he will see you outside the clinic and say, Doctor, what do you think? Am I doing okay? And he might be, just continuing his medication. But the thing is, what is his risk, basically? I think we have tools and we have to use these tools. In the past, we have the tools to have a risk assessment, including a simple ACR or predicting, cardiovascular mortality and predicting, adverse outcome for the kidneys, a very simple test. EGFR, it's not just the EGFR, and basically you have to see for doubling of serum creatinine, which also will be a risk assessment for our patient. But I think we have to go to the next step also. The new guidelines for KDUKI guidelines basically is to use an external validated formulas in order to predict your patient risk. We are all familiar about these graphs and tables where we have the albuminuria and the EGFR, very simple tool in order to predict the risk of our patient. And not to forget to see those patients and try to calculate their cardiovascular risk. And I think we should shift from risk assessment to risk prediction. And this is the very important aim of our therapy. Now, proteinuria is a key risk marker, basically. Why? Because it's a strong independent predictor of CKD progression. It's a predictor of cardiovascular events, it's predictor of mortality. So reducing the proteinuria will improve the overall renal outcome. Why proteinuria is bad? Because there will be faster EGFR decline, then there will be increased inflammation and fibrosis and accelerated nephron loss, and this is very important here. So in this graph, we could see like having even an ACR of around 3%, that might subject a person to lose around 20% of their nephron mass. And having a GFR less than 60, then we could lose maybe 20% of, more than that also, like around 20% of our nephron mass. Now, back to Haji Ali here. So what is his risk? When we saw the numbers, they were like borderline. Now we have a proteinuria. And let us try to predict his risk here. This is the simplest tool that we use in our clinic on daily basis. And I'm sure that all of you are aware of it. Now, so those number of GFR of 112 and HbA1c, they are not benign, basically. He has a moderate risk of having a progression of his kidney disease. And knowing that in the past we were having only, controlling his HbA1c, aiming for the numbers, controlling the blood pressure, aiming for the numbers with confusing numbers every time, aiming for a weight, smoking cessation, physical activity, protein restriction, and we had basically the evidence from using the ACE and ARB, and probably like most of those patients will be started in a small dose of an inhibitor or angiotensin receptor blocker. However, that was not enough because 6 months later, Haji Ali had more proteinuria and his EGFR dropped farther. And now, if we go to predict his risk, he's a very high risk, basically. This guy is going to lose his kidney. So there is something, and what is the residual risk of the kidney? So in the past, 20 years ago almost, we are playing on this hemodynamic factors. And we could see like in the renal trial and the IDNT trial, basically, irbesartan and losartan, basically these are the two landmark trial that we use as nephrologists for many years. We could see that we have reduced the risk, basically. We have reduced maybe the proteinuria. We have controlled the blood pressure a little bit. But can we see how much residual risk we have? And this has been for many, many years now, all right? Now, finally, we had something very interesting, and we have something now, at least. Okay, so we have this SGLT2 inhibitors, okay? And of course, which is standard of care. And I hope it will be standard of care because unfortunately, we have these quotas in health centers that not all the patients will receive SGLT2 inhibitor. And I think this has to change basically because unfortunately, these are novel therapy. And you could see from here how much they change. They're very important game changer. We have reduced the risk of our patient. We are preventing, end-stage renal disease. We are preventing, renal failure. But data from the Credence and DAPA-CKD showed like still we have residual risk, okay? And this risk between around 10 or 11%, some of the patients will still progress despite using the standard of care therapies. So now we were focusing mainly in hemodynamic effect, and that was mainly by the ACE and ARBs. And also the use of other like, thiazide, calcium channel blocker, and of course the novel SGLT2 inhibitor, which played a great role. But with the SGLT2 inhibitor, we had another player, which is basically the metabolic factor, which has really changed the game and you know the progression for our patient. But we still have this gap. What about inflammation? What about fibrosis? Are those patients really at risk of inflammation and fibrosis? Now, I think we have to understand, and we are understanding now. I mean, classically in medical school, when we say diabetic nephropathy, we'll speak about the Schimmelstein-Wilson, you know, and the glomeruli, basically. But now we discover that there is more of the tubulointerstitial damage, basically. Tubulointerstitial inflammation, okay, ongoing inflammation, for a variety of reasons, for medication that we are using unnecessarily, for infections, and we understand more the role of the tubules, basically, and the damage happening in our kidney, basically. And there will be this glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and there is a role for which increase the CKD progression. So what about mineralocorticoids? Okay, they've been there for many years. They're very beautiful for controlling the blood pressure and the overactivation of the mineralocorticoid axis. However, they were having some side effects. So now we have this novel group of medication, the non-steroidal mineralocorticoid antagonist. They will reduce the mineralocorticoid overactivation, and they are predicted to reduce the inflammation and organ damage in the kidney. The two main studies which has been done, which is the Fidelio and the Figaro studies. Now, the Fidelio, basically, the primary outcome was basically a renal outcome. The Figaro main outcome was cardiovascular outcome. However, both of the study interchangeably, they had secondary outcome in the Figaro. They have renal, outcome, and mainly they were cardiovascular. The opposite, the Fidelio, were mainly for the kidney, and the secondary was for the cardiovascular. Interestingly, they mix both of these studies, Figaro and Fidelio, to one study, which is fidelity study. And with that study, we had around, because the design of both the study almost the same, and basically they followed the same period of time for around 3 years. So the mixture of both had like around 13,000 patients, and came under the fidelity study, where it showed basically there is a 23% reduction in kidney, composite outcome, and there is a reduction around 20% in the end-stage renal disease. And the most important here, we mentioned about this proteinuria, which we were suffering with, and we don't have much of things to do about, around 32% reduction for proteinuria. Now, what about the cardiovascular protection? So it reduced the risk for the first heart failure around 22%, reduce cardiovascular death, and death is something very important here, around 17%, and reduce the new onset of heart failure to around 32%. Sometimes people who are not used to use the Finerenone, they will be surprised. We will have this, initial dip in the EGFR. And we know that this dip is secondary basically to the hemodynamic effect. The same applies for the SGLT2. However, if you are not familiar with it, you might be a little bit in, it's just same concept. ACE inhibitor, SGLT2 inhibitor, and Finerenone, basically, you might have this dip. You have to monitor, of course, for it, and you have to know is it related to it, because most of the time when you start the medication, you start in somebody who's having an angry kidney with a proteinuria. So sometimes you have to rule out also if there is no other causes. All right. Now, in terms of safety profile, the medication is very safe because it didn't drop the blood pressure, okay? And I can tell you that if you are thinking that is like a mineralocorticoid, no, it's not the medication to use for hypertension. And we know that that's an advantage because usually we do it as an add-on with maximum ACE or ARB inhibitor. All right. Then the other thing here in terms of HbA1c, there is no effect. Of course, gynecomastia, it's a novel type of medication which doesn't cause the gynecomastia. And acute kidney injury, it was not significant. The only thing that could happen is basically this hyperkalemia. And if you follow the guidelines, honestly, I don't remember that I have to stop the medication except of 1 or 2 patients which are, with quite advanced kidney disease. Now, I'll give you just like a guidelines here. In order to start the medication, just make sure that your patient has a potassium less than 4.8. Because if you start it more than that, then you might run into a problem. And the guidelines basically says like it has to be like less than 4.8. All right, you start with 10 milligram for a month, repeat it in a month, and then later on, if the GFR is more than 60, you could go to 20 milligram and should be safe. Whenever you do changes in the dose, you have to repeat the potassium and you repeat the kidney function just to make sure everything is okay. If the potassium is then more than 5.5, you have to hold the medication. And then later on, you could restart based on, certain precaution. Now, we are very also happy in nephrology nowadays. We have this novel type of potassium chelators, and many of them are actually, they are available here in Bahrain. Unfortunately, they are quite expensive. However, also that is a very breakthrough where we can continue with our medication. But honestly, also I don't remember that I have to use a potassium chelator for most of the patient here. If you do it in a good way, then you will not have a problem. And of course, as Dr. Dalal mentioned here, her talk, beautiful talk about the education. I absolutely agree with you about the education. Be careful with our patients. When it's the season of the date, then they will have problems, sugar and potassium. All right. Now, as nephrologists, we are always jealous from our colleague, the cardiologists, and they have their pillars for the heart failure with reduced ejection fraction. And those studies for having the pillars, they have beautiful studies showing like if you start the pillars of the treatment where they have this, the SGLT2 inhibitor, ACE and beta blocker and MRAs, basically, if you start them, each one individually, you reduce the mortality of the patient, but you don't reduce it much. You reduce it around 28%, 30%. But if you add everything all together, just in one shot, and that's what they do, you reduce the mortality by around 73%. And we, as nephrologists, we see many of their patients who are coming to us with a mixed picture of heart failure and they are a high risk patient. But we don't still have the evidence that we could start many of the medication altogether, okay? Till we started to have some evidence here. And basically, this is the confidence trial where they started empagliflozin alone versus finerenone alone, or finerenone and empagliflozin together. And we noticed that there is a very marked reduction in the proteinuria. So if using each one alone between 20 to 30%, but if you use them together after 6 months, we have a 52% reduction. So in confidence trial, we had like a 52% reduction in the proteinuria, and that was an interesting study because we use both of them together, like empagliflozin and the finerenone together. Hemodynamic, they did even the 24-hour blood pressure. There was no hemodynamic effect. Adverse effect, they had even little bit less of hyperkalemia than patients who use that medication alone. Now, the 4 pillar for diabetes type 2 with CKD, RASI, SGLT2, and non-steroidal MRA, and I think GLP-1 also is an important pillar for treatment of our patient. Traditionally, we go for having months till we start another one, like 3, then 6 months. There is a recent article, I strongly recommend you to see it, where they think of accelerated approach, like every 3 months we start one of them, or a rapid sequence, basically start a couple, keep the patient in close eye and close observation. And we are waiting actually basically for the guidelines to change, because I think this is the way to do, because time is passing and we are losing our patient. Guidelines, UK guidelines, we could use it for persistent proteinuria. KDOQI guidelines, it's an add-on basically if we still have this the proteinuria. ESC guidelines, there is definitely effect for cardiovascular and kidney failure risk, which will improve. ADA guidelines, it's considered slowing the progression of a chronic kidney disease. And I think we will need a little bit more evidence in order to have it, as a stage 1 guideline. Thank you very much.